Okay, let's move on to what is the last didactic lecture of this course and for all of anatomy, really. There might be some practice lecture exam review lectures from here, but this is really the last didactic lecture, the last new material that I'm going to introduce. And so in this lecture, we're going to revisit the pharynx, only this time looking specifically at the features on its lateral wall. And then we'll be looking at the palate a little bit. The hard palate, not so much. It's not very exciting. It's mucosa basically coating bone. But we're looking at the soft palate, which is a mobile structure made of muscle and has muscles that insert into it. And then we'll be looking at the nasal and oral cavities. The oral cavity is sort of the final frontier of anatomy. We always finish with the oral cavity. Now, in order to look at these things, the lateral wall of the pharynx, so stuff over here and along here and along here, as well as looking at the nasal and oral cavities, we have to bisect the head. It's the only way to really see those spaces, at which it's exactly the way it sounds. We're going to basically cut the head in half, and each half of the head is going to fall away from the other, which is going to allow us to look in the midline. Basically, stand in the midline and look laterally. Stand in the midline and look laterally. Now to do that, just to get oriented, I'm going to show you how we go about doing this process of bisecting the head. There's both soft tissues and bone in the midline that have to be cut. And so the first thing we're going to do is cut the soft tissues, and then last we're going to go off a bone saw and finish the job. But among the soft tissues we have to bisect include the soft palate right here and the uvula. Remember right here, this is soft palate separating the nasopharynx right here. I know this is nasopharynx because in this shadowy region anterior to it, we have nasal cavity. Down here below the soft palate and uvula, this part of the pharynx is the oropharynx. I know that because I'm looking at the root of the tongue right there, this shadowy region here, and here is the oral cavity. Okay, so we go off a scalpel and we're going to bisect the soft palate and the uvula, cut right down the midline of the thing, separating into a right and a left half. Now, remember, we're standing posterior to the pharynx, looking at the back side of the soft palate. So our right is the patient's right, and our left is the patient's left. I guess I shouldn't say patient, I should say donor. Okay, and then we're going to continue the bisection of the head, continuing to cut soft tissue. So this is the guy we're gonna bisect. You can tell he's worried. This is not a normal procedure. It's just a joke. We don't bisect heads of living people. Okay, but this is what we're going to do. We're going to cut the soft tissues. Okay, now to do that, generally we look for the nasal septum. And so the nasal cavity, which is deep here and deep to here, there are actually two of them. There's a right nasal cavity and a left nasal cavity, and they're separated from each other by a nasal septum. The nasal septum is an unpaired structure. There's not a right one and a left one. There's just one, right in the midline, or sort of right in the midline. The reality is we're not perfect, we're not bilaterally symmetric, and our unpaired structures do not sit perfectly in the midline of our body. Everything deviates to the right or left a little bit, as does the nasal septum. Everyone has a little bit of a deviated septum, and so you always want to look inside the nostril here and figure which side of the head is the nasal septum deviating towards. And the whole idea is we want to keep the entire nasal septum intact. We don't want a portion of it on the right side of the head and a portion of it on the left side of the head. We want to keep the nasal septum intact. So generally we find which direction it's deviated in. So in this guy, we'll say it looks like it might be deviated towards the right. And so when we cut the soft tissues, we want to kind of be biased a little bit towards the left to try to keep the nasal septum intact on one side. And so it looks like this guy is deviated just slightest bit to the right. Okay, so we're going to bisect to the left of the nasal septum. So we're just off the midline, a little pinch, just off to the left to try to keep the entire nasal septum intact on this side. Cut through the soft tissues of the nose, which is skin and cartilage. Up here is bone. Okay, that's bone. There's a right and a left nasal bone for the proximal part of the nose. And then we're going to cut right down and bisect the lip right through this little fossa right here called the philtrum, right down through the lip and bisect that. Okay, and then we make our bone cuts, and this right here, if you recall, is the crista galli, that portion of the ethmoid bone that the falx cerebri attaches to anteriorly, and we're going to bias things in the same way. Whichever side we we deviated towards to try to preserve the nasal septum, that's the side we're going to make our bone cut as well. And so in our subject, we went a little bit to the left to try to keep the nasal septum intact on the right. And we're going to do the same thing here. We're going to go to the left of the crista galli just slightly, just barely, just kind of barely nicking it, and make a midline cut, bias slightly towards the left, right down here, and cut down all the way through the maxilla between the two upper medial incisors. And again, in a different donor, we may very well cut on the right if the nasal septum is deviated slightly towards the left. It just depends on the donor. We want to keep that nasal septum intact. Okay, now we stop sawing after we saw through the hard palate, which is the roof of the mouth right here. Okay, we do not saw through the mandible, at least not initially. Now, eventually we'll bisect the mandible, but we usually do that afterwards. We usually go in 2 steps. We make this cut, and then we make this cut later. All right, now that positions us to look at the nasopharynx and the soft palate from the midline laterally. Okay, so it's like we're standing in the midline looking out laterally. And these two things kind of go together right here. And the reason for that is that the nasopharynx has multiple features, but among the features we find in the nasopharynx are a pair of muscles. And they're muscles that insert into the soft palate and basically elevate it to get it out of the way. And so these two things have an intimate relationship with each other. There are other things in the nasopharynx. It's not all about muscles that insert into the soft palate, but that's among the more prominent things we're going to look at. All right, so here's our bisected head. Now, in this illustration, they've gone ahead and bisected the mandible and bisected the tongue. That's okay. We're going to do that eventually, but usually that's not done initially, but it will be done. All right, and so this gives us the view that we need for studying the nasal cavity, as well as the oral cavity, as well as the lateral aspect features on the lateral wall of the pharynx right here. And this is only achieved by, again, by bisecting the head. And so what do we look for here? Well, here's the soft palate right here. This is the hard palate right there, which is composed of bone. There are actually 2 bones that make a contribution to it. This is maxilla right here, or the palatine process of the maxilla is right here. And there's a little bit of bone right here. This is called the horizontal plate of what's called the palatine bone. So 2 bones, maxilla and palatine bone, make a contribution to the hard palate. Otherwise, the hard palate is mostly lined with mucosa, and there's some nerves and arteries in here that I don't usually cover in this course. But we're going to focus here on now on the soft palate, which is made of muscle. All of this right here, and that's the tip of the uvula hanging down right there. So that's the soft palate, and we need to be able to elevate this, raise it and lower it as needed. Okay, and then down here, just get oriented, is the epiglottis. So this is basically the apex of the larynx right there. Okay, so that's the epiglottis there. The rest of the larynx is below this. Okay, and that's how we subdivide our pharynx into 3 segments again. So this is the nasal cavity. Therefore, this back here, this space right here, above the soft palate and behind the nasal cavity, is the nasopharynx right there. And you can see already there's a whole bunch of bumps and grooves in here. That's why we bisect the head, so we can get a good view of these things. Okay, some really, really important things in here, and even a few things you can't even see yet. That's the nasopharynx. Okay, now it's blue. And then down here, and this space right here, again, the same concept. We're behind the oral cavity, posterior to the oral cavity, this time below the soft palate, inferior to the soft palate, and above, superior to the epiglottis. And so here's another space right here, and that space is the oropharynx, and now it's green. That's the oropharynx. And then down here, posterior to the larynx, there's the epiglottis, which is our landmark here to show us where the larynx is. Below that is our laryngopharynx, and now it's purple. And so again, the same 3 parts of the pharynx can be seen here, just named for what is directly anterior to them. Okay, now let's focus now on the nasopharynx. Okay, let's look right there. And again, we're concentrating on this space right here, located posterior to the nasal cavity and superior to the soft palate. Okay, and that gives us this view here. We can see now we're looking at nasal cavity and nasal pharynx. We're looking at the lateral wall here. The nasal septum has been removed right here. And so right there, again, this is the lateral wall of the nasal cavity and the lateral wall of the nasal pharynx. So let's work from anterior to posterior here. We can kind of get oriented here. Here's the nose right here. So the upper part of the nose is composed of bone, of overlying skin, of course, and this is nasal bone, so this would be the right nasal bone, because it's the right half of the head. And you can see most of the nose is otherwise composed of cartilage and skin. That's why when you look at a skull, there's a giant gaping hole right here, and that's because most of what we know as the nose is not made of bone. This is cartilage. That's this blue stuff right here and overlying skin. Now the nose hole right here, what we normally think of as the nostril, this is referred to as the anterior nares. Okay, that's that opening right there, the anterior nares, and that takes us into a little space right here where we find a lot of hair, just right in here, and that little space right there is called the nasal vestibule. And that's where you put your finger, if you're into that sort of thing. Now, if you put your finger in this far, you'll probably have to go to the hospital because you've probably really damaged your face. So don't do that. This giant chamber right here is the rest of the nasal cavity, and it's formally referred to as the atrium of the nasal cavity. So the nasal cavity is quite large. The part of that, what we normally think of the nose, it's really just the nasal vestibule. It's a relatively small space. Now let's go all the way back here into the nasal pharynx and start looking at the features that we might see. And right here in the lateral wall of the nasal pharynx, we find the opening of a tube. Okay, the tube that this opens to is called the auditory tube, the eustachian tube, or the pharyngotympanic tube. You call it any one of those three things. I don't care which one you use. There's the famous eponym. Okay, this is a name basically indicating what it connects. It connects the pharynx with a space called the tympanic cavity, or you just call it the auditory tube because it's related to the ear. Okay, but that's the opening of it there. That's the opening of the tube right there. And this is specifically a communication between the nasal pharynx and the middle ear cavity, which is also called the tympanic cavity, which is really an air sinus with some bones in it. Okay, we're going to see in a little bit that the skull is hollow. Well, not completely hollow, but there's little spaces all over the place. There's a sinus here, sinus there. These are different than venous sinuses, which are filled with venous blood. These are air sinuses. They're just really just hollow chambers within the bone that helps make our head a little bit lighter. Okay, so there they are right there. And one of those air sinuses is the middle ear cavity, or tympanic cavity, even though we don't usually refer to it as an air sinus. The fact is it is. It's just got some bones in it as well. Okay, and we're going to use it to transduct auditory, basically pressure waves in air is what I'm trying to say, and transduce that into an electrical signal that's being transmitted by cranial nerve 8. I don't know why I'm having so much hard time with that, getting that sentence out, but that's the idea. Okay, now the thing with these air sinuses, these guys and the middle ear, which we can't see in this diagram, is that you can't have just a whole bunch of hollow spaces within the skull that have no communication with the outside world, because there are changes in barometric pressure happening every single day. You can change altitude. You can go to the top of a mountain or to the bottom of a valley where the pressure changes. And if you don't have a communication with these spaces with the outside world through the nostril right there, you're going to feel a pinch. You're going to feel pressure in there. It's going to hurt. Okay, so we need to have communications. We'll talk about those communications as we proceed through this lecture. But the communication between the middle ear and the outside world is through this tube right here, the auditory tube, which is going to connect the middle ear with the nasopharynx, right at this opening. Nasopharynx can communicate with the nasal cavity easily through here. And the nasal cavity communicates with ambient pressure, the outside world, through the anterior nares. And so what this allows us to do is basically equalize the pressure in our middle ear through this communication through this tube all the way to the middle ear. We can adjust that pressure within our middle ear. So that tube's got to be open. That's why we got it. Okay? This just gives another view. This is a coronal view of the whole deal right here. And you can see that's an ear right there. This is the external ear canal right there. Okay, this would be the location of the external auditory meatus, and the skull would be right there. And at the end of the external ear canal, there's a tympanic membrane. That's the eardrum. And on the other side of the tympanic membrane, right there, that's the tympanic cavity, the middle ear right there. And you notice what we have in there, a bunch of little bones. We have a malleus and an incus and a stapes bone, and these bones serve the purpose of transducing sound waves coming in there, impacting the eardrum, moves these little bones, and that information is translated by the cochlea into an electrical signal that's going to be transmitted by cranial nerve 8. But anyway, that's an airspace, and it's got to talk to the outside world, or you're going to feel a pinch right there. It's going to be painful. And the communication with the outside world is along this eustachian or auditory tube right there, down to the nasal pharynx. That's the communication right there. Notice it starts off as a narrow tube and flares out at the end. We'll come back to that concept in a second in terms of the naming of this thing, but it starts off narrow and flares out at the end. Okay, that's it right there. That's the opening of the auditory tube in the lateral wall of the nasal pharynx. There's the auditory tube right there. That's the communication. Okay. Take a little side note here. It's a good time to talk about otitis media or middle ear infections, and we can see what happens. These things, otitis media, so otitis is inflammation of the ear. Media means middle ear. This would, if we have inflammation out here, that would be called otitis externa. There's no such thing as otitis interna that I know of, but otitis media means inflammation of the ear, the middle ear. Okay. Now, one of the things it's more common in children, and the reason is this: you look at the contrast the anatomy right here in an adult. What happens is we develop. We'll start in the child here because we go this way when we develop, not this way. Okay, but we start off like this. In a kid, the auditory tube is more horizontal right here. And so what happens is this doesn't drain as well. We've got problems in the middle ear and it needs to drain. It doesn't quite drain as well as an adult because the auditory tube is more horizontal. By the time we reach adulthood, the auditory tube is descending there, and so this middle ear is capable of draining fluid pretty easily right down there through the auditory tube into the nasopharynx, and then it comes out our nose. Okay, so adults aren't as prone to middle ear infections. Kids are more built for middle ear infections because they don't have a good drainage system for their middle ear. But that's the usual anatomical explanation for the higher incidence rate of otitis media in kids versus adults. What are the consequences of otitis media? So otitis media, again, is an infection in this area right there. Again, there may be a pathogen involved. There may be an infectious disease involved, or there may not. But there's this otitis media is going to occur here. Now, it can spread. Okay, middle ear infection isn't that much terribly of a bad thing. I mean, it can be treated effectively. But it can progress to things that are more serious. And to understand how it can progress, we need to look at the anatomy right here. So this is a section, a parasagittal section through the temporal bone. This is temporal bone right here. There's the mastoid process right there. We can see how close it is to the middle ear. This is the internal jugular vein down here. There's our carotid sheath. Okay, this makes this the internal carotid artery right there heading towards the cavernous sinus. Okay, and what happens is the internal jugular vein will start right here at something called the jugular bulb and then drop straight down. This is the very end of the sigmoid sinus, which, as you call, drains into the internal jugular vein. Now up here, the roof of the middle ear right there is a very, very thin plate of bone called the tegmen tympani. You can see how thin it is. And once we go above that, we're basically in the middle cranial fossa right there, which of course is lined with dura mater right there. And of course there's arachnoid mater sitting right on top of that. Okay, and so we got meninges sitting, coating this tegmen tympani. Okay, and so we're set up for the spread of middle ear infections in three possible directions here. Okay, first it can spread down. So if a middle ear infection is not treated effectively, it can spread inferiorly, and let's say it's a bacterial infection, they can basically eat away at this bone right here, the bacteria that is, eat away at this bone right here and pass right through there and into the internal jugular vein. When an infection spreads from the middle ear into the internal jugular vein, now we've gone from otitis media to venous thrombophlebitis, which is basically an infection of the venous system, and that's significantly more serious than otitis media. point is middle ear infections need to be addressed early on so they don't progress to something worse. That's one direction this thing can spread, in the red direction towards the internal jugular vein. Another direction it can spread is superiorly along this purple arrow right here. And so if the infection eats its way through the tegmen tympani, the next thing it finds is dura mater. Okay, and once the infection spreads to the dura mater, now we have meningitis. So otitis media can become meningitis if it's left unchecked. If it eats its way through the dura mater and arachnoid mater, the next thing it finds really is the brain. And so that can even progress to encephalitis. And there have been cases of unaddressed middle ear infections that progressed to basically an infection of the temporal lobe of the brain. You can actually get an abscess inside the temporal lobe, which obviously is quite serious. Okay, the other thing along this purple line there, you can also get spread into the dural venous sinuses. Remember, we had dural venous sinuses that are encased within dura mater, enclosed within dura mater. It just depends. A slightly different superior direction might take the infection into one of the dural venous sinuses, either the sigmoid sinus or one of the other sinuses, and that's another way you can get thrombophlebitis. So the sigmoid sinus says down there, but this is a strange cut right there. It's hard to get oriented, but the sigmoid sinus is climbing up this way, and so there could be a spread into the sigmoid sinus going this way, superiorly, and then once again you have thrombophlebitis. Okay? And then there's one more direction we can go, and this is the direction of this light blue arrow. If the infection passes posteriorly, it can get inside the mastoid process. The truth is, the mastoid process is hollow or partially hollow. It has all sorts of these little mastoid air cells in it. Okay, it's not solid bone. And there's a natural communication between the middle ear and the mastoid air cells. Okay, it's not labeled here, but it's called the aditus. Aditus is a hallway. Right here is the aditus of the mastoid air cells. And it's just a natural passage right here into those mastoid air cells. So if the infection works its way posteriorly, the mucous membrane of these hollow spaces can get infected, and then you have mastoiditis. If you have to choose between these things, mastoiditis is the one to get. It basically presents as pain behind the ear, basically a painful, tender mastoid process. The upper part of the sternocleidomastoid, which of course is attaching to the mastoid process. Basically, if every head movement there's a little bit of pain, the bone itself is tender, but it's not particularly life-threatening. So you got to get one of these things. You want mastoiditis, but there's no guarantee which way the infection is going to spread. Anyway, those are the things I want you to know. I want you to know how middle ear infections can progress to something much more serious. All right, returning to our nasopharynx, there's our opening in the auditory tube right there. And then around it, we see a number of little bumps and ridges. And so right above the opening of the auditory tube, sort of going horizontally this way, there's a little ridge here called the torus tubarius. And this is basically just cartilage of the auditory tube covered in mucosa. All of this, I don't know what color this is, this reddish hue kind of stuff there is indicating basically mucosa, which is just this soft, wet membrane lining everything inside the nasal cavity and the nasopharynx. And right underneath this mucosa right here is cartilage. And it's cartilage of the auditory tube, and this thing is called the torus tubarius. Torus is a ring, so it's like a ring-like structure we just find right above the opening to the auditory tube. And then right behind the torus tubarius, right back here, there's a space here called the pharyngeal recess right there. Just a little tiny space, like just right in here. And in the back side of the pharyngeal recess is something called the pharyngeal tonsil, okay, which is lymphoid tissue. And there's a number of different little sentinel lymphoid-like tissue structures throughout the head right here. This is one of them. And this is called the pharyngeal tonsil right there. If it's enlarged, if this thing swells up, becomes inflamed, we refer to it as an adenoid. And so when people say they've had their adenoids removed, they're talking about this structure right there, the pharyngeal tonsil. Imagine if this thing swells up right there, it can close off the airway right there a little bit. We still breathe through our mouth, so it's not a life-threatening situation, but it is unpleasant and uncomfortable. And so sometimes you have to go in and get rid of these things. But that's the pharyngeal tonsil. If you say adenoid, that's fine too. Okay? All right, let's go in another direction here. We go down. Like I said, this is the torus tubarius above the opening of the auditory tube, kind of going horizontally. And we pass this way, and then the ridge, there's a ridge that turns down, and it's vertical. On the back side of the opening of the auditory tube, it's heading down. And so this is another mucus-covered ridge right there. And the name of this ridge is called the salpingopharyngeal fold. Okay, now I told you when we looked at the auditory tube in coronal section, remember I told you it starts off narrow at the middle ear and then flares out as it approaches the nasal pharynx. And remember I told you when we dealt with the pelvic cavity, the fallopian tubes are shaped like that. They start off narrow, okay, at the isthmus, and then they flare out by the time you get to the infundibulum where the fimbriae come off. Consequently, the fallopian tubes are kind of nicknamed the salpinx. Okay, a salpinx is a trumpet that flares out at the end. Well, we got another tube that flares out at the end, and so we're back to salpingo stuff again. So salpingectomy is removal of the fallopian tubes. Remember, the mesosalpinx is that part of the broad ligament that attaches to the fallopian tube. So we're back to salpingo stuff again because we have another structure, the auditory tube, that starts off narrow and flares out at the end. And so we've got this fold coming down from the auditory tube towards the pharynx right there. It's actually kind of just blending in with the pharyngeal wall, and so it's called the salpingopharyngeal fold when it's got mucosa on it. Now, what is creating this ridge should be the next question. Why is there a ridge here? Well, there's a muscle underneath there, and if I were to strip off this mucosa right here and then look underneath that, I would find a little muscle called the salpingopharyngeus muscle. So salpingopharyngeus muscle, I slap mucosa on top of that. Now I've got a salpingopharyngeal fold, which is the mucosa plus the muscle combined. Okay, that's this ridge right here. And then there's another ridge right here that looks like it's coming out of the auditory tube. There's the opening of the tube right there. And it's kind of a wider ridge right here going this way, heading right for the soft palate. And this thing is called the torus levatorius. Okay? And again, torus levatorius by definition means there's mucosa on it, but you should be asking what's creating this ridge right here. Why is there a little bump right here? Well, the reason is that there's a muscle underneath this thing, a really, really important muscle that's going to go towards the soft palate. What's underneath this mucosa creating that bump is a muscle called the levator veli palatini. Okay? So let's take off the mucosa and look at the muscles here. So we've stripped off the mucosa off these are pharyngeal constrictors right here. That's the back wall of the pharynx. Stripped all the mucosa off that. Let's look directly at the muscles. There's the opening of the auditory tube right there. There's that cartilage I told you about that's forming the torus tubarius right there. And there's this vertical fold right here coming down. Now we've taken off the mucosa here. So it's not the salpingopharyngeal fold anymore. We're actually looking at the muscle. And this is the salpingopharyngeus muscle. So it's a muscle that just takes its origin off the auditory tube, and it's a weak elevator of the pharynx, basically. It can basically pull this way, pull up on the pharynx. But more importantly, here's a soft palate, which is made of muscle right there. The uvula would be right about here. There's a soft palate. And there's this other muscle right here. It looks like it's pouring out of the auditory tube. There it is right there. It looks like it's pouring out like a waterfall, pouring out of the auditory tube right into the soft palate. Okay? And that's an elevator of the soft palate. Okay? Called the levator veli palatini. Again, if I slap mucosa on top of this, I would call that the torus levatorius. Okay? And this muscle, you can see what's going to happen. If this muscle contracts, origins here, insertions here, it's going to pull this way. It's going to lift straight up on the soft palate, elevating it. Okay, veli palatini. Velum is a sail. Palatini means of the palate. So sail of the palate is what velum palatini means. That's a direct reference to the soft palate. Okay, in Latin, it's called the velum palatini, meaning the sail of the palate. Okay, levator veli palatini. Okay, means the elevator of the sail of the palate. The elevator of the soft palate. Again, I just try to translate these words a little bit to try to demystify them so you're not memorizing, you're actually able to kind of reason out why this guy is called what he's called. He's elevating the soft palate. What else are you going to call him? Of course he's levator veli palatini. Okay? So that's that. Now, let's go and do a little bit of osteology here, because there's another muscle I want to talk about that also is going to have a role in elevating the soft palate. Now, when we look at the bones right here, so this is to take off everything here, we're looking right at the lateral wall of the nasal cavity right there, just looking at bare bones. There's the hard palate right there, which remember I told you is composed of maxilla, the palatine process of the maxilla, and the horizontal plate of this palatine bone right here. And this yellow bone right here is called the sphenoid. Again, we've encountered the sphenoid bone before. Very, very complex bone, has lots of parts. Okay, there's just one of them. There's not a right and a left one. It's one big bone that's located in the midline and extends laterally. Okay, that's the sphenoid bone right there. Okay, now hanging down from the sphenoid bone this way is the pterygoid process, which we've talked about previously, especially at the infratemporal fossa. So this is all pterygoid process, two wing-like projections hanging down from the sphenoid bone. And each pterygoid process, the left pterygoid process and the right pterygoid process, this would be the right one, has two plates to it. There's a plate and there's another plate right there. Okay, this is the medial plate right here of the pterygoid process of the sphenoid bone. Okay, to get oriented, remember, we bisected the head, which means we are standing in the midline. That makes this guy closer to the midline than this guy. That's the medial plate right there. So the medial plate of the pterygoid process of the sphenoid bone. And then right here, there's this little hook-like projection coming off it right there called the hamulus. And so this guy is the hamulus of the medial plate of the pterygoid process of the sphenoid bone. If you really want to, go crazy with this, if you said hamulus on a lab exam, it's probably good enough for me. Said medial plate of the sphenoid bone is probably good enough for me, but this would be really cool if you wrote all this. But that's the hamulus right there, and this is going to act as a pulley for a muscle right there, this little projection right there. There's going to be a muscle tendon that hooks around this thing. Okay, and so let's go back to this diagram. There's another muscle lurking right behind this right here. So this bone right here, this is the medial plate of the pterygoid process of sphenoid bone right there. This is sphenoid bone there. Okay, this is the pterygoid process hanging down from it. We're looking directly at the medial plate right there. Well, lurking behind this guy, well, there's the hamulus right there. So there's the medial plate coming down, and there's the hamulus, that little hook-like projection coming off the medial plate right there. Now, lurking lateral, I'm going to say behind, but really properly I should say lateral to this, is a muscle. You can see the muscle belly right there hiding behind this medial plate, and then you can see its tendon right here going into the soft palate kind of from lateral to medial. So it's going kind of down this way, and it's hooking around this hamulus right there and inserting into the soft palate from a lateral direction. Okay, and this guy is called the tensor veli palatini. It's the tensor of the soft palate. Okay, so this guy's a little more shy in terms of practical identification. The levator veli palatini is right out there in the open. You can't miss it. There's no bone covering it. It looks like it's pouring out of the eustachian tube. This tensor veli palatini is more shy. He likes to hide behind this bone. And it'll come down, and its tendon will hook around this little hamulus and approach the soft palate from the lateral side. Whereas the levator veli palatini is approaching it from the superior side. It's going to lift straight up on it. The tensor is going to pull laterally on the soft palate. Okay, so by putting lateral tension on the soft palate, it's going to help elevate it. Okay, so here's just another view of these muscles to get a better view of how they're oriented. And so this is a posterior view. This is a view as if, again, we're behind the head, a head that's been disarticulated, and so we're looking through the back side of the pharynx. Okay, looking anteriorly. These are the nasal cavities right here, and the nasal pharynx would be here and here. Okay, and so on one side, obviously on both sides, right side and left side. Again, we're posterior to the donor, so our right is the donor's right, our left is the donor's left. On both sides, there's both a right and a left levator veli palatini. This is it right here. Okay, and on both sides there's a right and a left tensor veli palatini. But for the illustration purposes, the levator is being shown on the right side. So we're seeing the right levator veli palatini. The right tensor veli palatini is hidden. On this side, the artist has cut the left levator veli palatini here and here to reveal the more anteriorly placed tensor veli palatini. So that's just, all of that is just for orientation. Now let's look at the muscles. Here's a soft palate down here. Here's a uvula hanging off the back side of it. And you can see the levator valley palatini right here. Kind of a very, very simple approach there. It's just coming straight down and inserting directly in the soft palate. When this guy contracts, origins here, insertions here, it's going to just pull this way. It's just going to lift up on the soft palate. That's why it's the levator valley palatini, the elevator of the soft palate. Tensor is coming down. There's a muscle belly, and then right here you can see a tendon right there. And there's the hamulus right there, which is a pulley system that allows the tendon to change directions. And so the muscle, when it pulls, the origins here, insertions here, when the tensor valley palatini contracts, the tendon is pulling this way. It's pulling laterally towards the hamulus. And so what this is doing is putting lateral tension on a soft palate, which helps elevate it. Okay, it's like cinching the soft palate. It's pulling out on it laterally from either direction, pulls out this way, pulls out this way, and by putting tension on it, it elevates it. Okay, so you can see right there. In real life, it really does look like this in the sense that the levator valley palatini, you don't see much tendon. It's muscle belly all the way down. Tensor valley palatini has a very clear tendon to it. You can see muscle belly superiorly, but you can see it change over in sort of a silvery white color pretty quickly here and here. Okay, but that's how the muscles act. That's how they're situated. Okay, now we got to talk about nerve supply. Okay, they have different nerves. Okay, the levator valley palatini follows the general rule that the soft palate is supplied by the vagus nerve, cranial nerve 10. I say the general rule because there's actually muscles inside the soft palate as well. The soft palate itself is really made of muscle, and there's actually a muscle inside the uvula called the musculus uvulae, which I'm not asking you to know. When that contracts this way, that's it right there, it actually also lifts the uvula a little bit by shortening. The muscle shortens this way, and that helps elevate the soft palate as well. So the soft palate itself is really made of muscle. There's intrinsic muscle there that's all supplied by the vagus nerve, as is the levator valley palatini. Now, the exception to the rule that the soft palate is supplied by the vagus nerve is the tensor valley palatini. This muscle is actually supplied by our old friend cranial nerve V3. The mandibular division of the trigeminal nerve is actually what's supplying the tensor valley palatini. That's the exception to the rule that vagus is motor to the soft palate. And just to understand why trigeminal of all things, why would that be supplying a muscle whose job it is to lift the soft palate? And to understand it, let's just look at a little bit of osteology right here. Also gives us another view of the vector of pull of the tensor valley palatini. Okay, so just get oriented here. Here's the hard palate here. This is the palatine process of the maxilla. This is the horizontal plate of the palatine bone. All of this collectively is hard palate, which means the soft palate would be directly behind this. Soft palate would be located right here, okay, separating the oral cavity from the nasal cavities, which we can see in those dark shadows right there and there. So our soft palate would be right about here. Okay, now, right here is a little impression right here. This space right here between the medial plate and the lateral plate of the pterygoid process. So the yellow bone is sphenoid. There's the pterygoid process. This is medial plate, and this is lateral plate. Excuse me. No, that's right. I got it right first slide. This is medial plate, this is lateral plate. And the space between them, all this space in here is called the pterygoid fossa. Now there's a little impression here, a little thumbprint here, another little fossa right here called the scaphoid fossa right here, just lateral to the medial plate. And this is actually the origin of the tensor valley palatini. This is where the muscle is attached at its origin. Remember, its insertion is going to be the soft palate, which is right here. And right there, we see the hamulus of the medial plate of the pterygoid process, of the sphenoid bone, of the skull, of the body of planet Earth. Anyway, you get the idea. There's the hamulus right there. And so the vector of pull of the tensor valley palatini is going to be like this. So it's pulling this way, okay, towards pulling out on this soft palate, which would be right here. Remember, there's going to be another one on the other side. It's pulling out laterally, and the muscle tendon is going to hook around the hamulus right there. And the origin of the muscle belly is right there in the scaphoid fossa. Okay, but let's return to this idea of why trigeminal nerve. Well, right there is the foramen ovale. Okay, cranial nerve V3, remember, is entering the infratemporal fossa. This supply, well, do lots of things, ultimately to supply the lower teeth and and the cheek and the anterior 2/3 of the tongue, as well as being motor to all those muscles of mastication. It's got a lot of work to do in here. But it's right here. There's the foramen ovale where V3 is coming through. There's the tensor veli palatini. Why not just pop off a little branch that goes like this and supplies that muscle belly right there? So really it's another example of why V3? Well, it's there. It's right in a perfect position to supply the muscle because the muscle is right next to the hole that the nerve is coming through. So that's why it's V3 really, is why it supplies the tensor veli palatini. All right. Let's go back to this view again. Again, here's our nasal pharynx right there. Now, this time we've got the nasal septum in place. Okay, so the nasal septum is in place right there, separating the left nasal cavity, which is where we are, in the right nasal cavity, which is on the other side of this thing. Okay, now there's an opening right here. Remember we talked about openings and spaces. To me, a space is like a room. There's a space right there called the nasal pharynx. There's another space right here called the atrium of the nasal cavity. Okay, they're like rooms, and between rooms there are doorways, and the doorways are openings connecting those spaces. And so this is the opening right here. This is the doorway that we walk through to go from the nasal cavity into the nasal pharynx, or vice versa. And this is the opening right there, and it coincides with the posterior edge here of the nasal septum. And that opening right there, and there's two of them. There's a right one and a left one for each nasal cavity and each side of the nasal pharynx. This opening that's circled here in white has two names. We can call it the quana or the posterior nares. Remember, the anterior nares is right here. So quana or posterior nares is right there. And that is the official opening between the nasal pharynx and nasal cavity. Okay? To get from one space to the other, you got to pass through that opening. Okay, let's go on to the nasal cavity a little bit and talk a little bit about that. Again, we're going to get a view of the lateral wall of the nasal cavity. Well, first let's do the nasal septum. Okay, so the nasal septum does have a skeleton to it. Okay, it's actually composed of three different portions here. Basically, the skeleton of the nasal septum consists of cartilage up front. Remember I told you most of the nose is made of cartilage and skin. And there's this giant gaping hole here that we normally see in a skull, and most of the nose stuff has decomposed. Well, the nasal septum, also the anterior third of it or so, is made of cartilage. Okay, that's called septal cartilage. And then the back side of the nasal septum is contributed to by two bones: the ethmoid bone here in purple, and then there's this little green bone here called the vomer. Okay, vomer is not a right and a left one. It's an unpaired bone, and it's really not. It's kind of a funny little bone here. It's kind of triangular shaped, and it's just a little plate. It's a little chip of bone right here that sort of makes up the posterior, inferior, I don't know, third of the nasal septum. And then the ethmoid bone. Remember, there's our crista galli right there. There's our crista galli. And then this little part of the ethmoid bone that sticks down into the nasal septum is called the perpendicular plate. Okay, that's the other part of the nasal septum. And so collectively, this is it. This is the skeleton of the nasal septum. I slap mucosa on either side of this thing, and that completes it. And there'll be some nerves and arteries, which I'm not going to cover in this course. You can actually see a little groove here for an important artery. That's the one that usually gets damaged during a nosebleed. I'm not going to talk about that in this course. It's one of the things I'm kind of leaving out to kind of lighten the course a little bit. But that's the nasal septum and its skeleton. Okay, now let's look at the lateral wall of the nasal cavity. So this would be if we remove the nasal cavity, the nasal septum, and look laterally, and we see all these structures here on the lateral wall. So let's do a little bit of the osteology here so we know what bones are involved. Okay, this blue bone right here is the frontal bone. There's our nasal bone right there that's unlabeled. That's the upper part of the nose. Maxilla is all this in green. There's the palatine bone right there. So it's kind of an L-shaped bone. It's got this horizontal plate that's making part of the hard palate. And it's got this piece right here that's sort of vertical. And right here is the ethmoid bone in gray. There's our crista galli sticking up. Okay, so got through all that. Okay, the other things we see, other portions of the ethmoid bone. So remember I said there's a perpendicular plate coming down that makes up part of the nasal septum. That's obviously in the midline, but on the lateral side of the wall here, the ethmoid bone also makes a contribution. It's making a contribution to the lateral wall, and we see these little bumps right here that are continuous with each other, sort of wrapped around, and they're continuous here anteriorly. Well, this bump right here is called the superior concha. And then this one right here is called the middle concha, okay? And they're all part of the ethmoid bone right here, okay? And then down here, that's the inferior concha right there. Now, he's his own bone, okay? He's a bone in and of himself. The inferior concha is a bone. It's not a part of another bone. It's its own thing, okay? And it's on an island by itself. It's not continuous with these guys because they're separate bones, okay? Now, here's just a coronal view of these conchae. So here's our nasal septum right there, separating the right and left nasal cavity. And we can see what the conchae are doing. They're basically projections coming off the lateral wall of the nasal cavity. The middle concha is shown here. The superior concha really isn't seen well here because it's small and we're not at the right plane. Middle concha, inferior concha. There's the palate right there. Okay, so why do we have these things? And notice remember, these things are covered with mucosa. Okay, mucosa going all the way around. There's more mucosa here. There's an opening right here. If I go like this and go through here, I find myself in this giant chamber right here. We'll talk about that in a little bit. Remember what I said, we have these air cavities called air sinuses throughout the skull, and we've got communications with the outside world. We'll come back to that. But why do we have these conchae covered with mucosa? And the reason we have these is that we have to humidify air coming in. So as we inspire air through our anterior nares into our nasal cavity, okay, that air may be dry. We are wet on the inside. You can't just breathe in dry air and have there be no ramifications of that. Okay, that will cause physiological problems. Okay, we are wet on the inside, and the air that comes in must be made wet so it matches the inside of our body. And that wetting process is facilitated by these conchae. Remember, there's a general strategy. Nature likes to wrinkle things up to increase surface area. And so the conchae are basically there to increase the surface area of the nasal cavity. Okay, why do we want to increase the surface area? We want to expose as much wet mucosa to that incoming air as we can to try to moisten up that air as much as possible. But that's it. That's why the conchae exists, to humidify air as it's passing into the respiratory system. Okay, so that's why we have conchae. Now let's deal with some spaces here. Okay, because there's a space here, a space here, a space here, and a space here. I'm going to basically put the spaces over here. And basically we're going to start, here's the hard palate right there. We're going to start counting up from the hard palate right there. Okay. And this first space right here, this little channel right here, that air is going to pass through to get humidified, before it passes back into the nasal pharynx, oral pharynx, into the larynx and the trachea. That's going to be the path it's going to take. Okay, it's going to pass right through this channel right here where it's being exposed to lots of surface area, both this part of the hard palate right there, as well as the whole surface of the inferior concha. This little channel right here, this little space between the hard palate and the inferior concha is called the inferior meatus. Okay, that's the inferior meatus. Okay, and then above the inferior concha, we have a middle meatus. Okay, above the middle concha, we have a superior meatus. And then above the superior concha here, we have something called a sphenoethmoidal recess. Again, this is sphenoid bone in yellow, ethmoid bone is in gray, and this little space right here in between those two bones is called the sphenoethmoidal recess. So again, counting up, best way to identify these, if you're looking at a view of the lateral nasal wall, easiest thing to do is get oriented, find an easy easy landmark, and start counting off. There'll be teeth hanging off down here, probably off the maxilla. Here's the hard palate. Let's start counting up. Hard palate, inferior meatus, inferior concha, middle meatus, middle concha, superior meatus, superior concha, sphenoethmoidal recess. Okay, so again, hard palate, inferior meatus, inferior concha, middle concha, superior meatus, superior concha, sphenoethmoidal recess, and this right here is the cribriform plate of the ethmoid bone right there, flanking on either side of the crista galli. Okay, let's talk about the cribriform plate of the ethmoid bone for a second. Okay, this is the nasal cavity. After all, one of the things we do with it is smell with it. So we need to smell stuff, okay, and that gets into these little nerves right here. Now, we're looking at the anterior cranial fossa right there. In dark yellow is the ethmoid bone. There's the crista gallia on either side of it, is this little plate on the left side and right side that has all sorts of little tiny holes in it. And those holes are the olfactory foramina. Passing through those holes is cranial nerve 1. I say is cranial nerve 1 like it's a single nerve. The reality is cranial nerve 1 is really a collection of thousands of little nerves. Okay, so really it's cranial nerves 1 if you really want to be proper, or you just call them the olfactory nerves. But the point is this: they're passing through those holes because they need to pass from the nasal cavity to the anterior cranial fossa. Why? Because the olfactory bulbs are sitting right here, and that's where the olfactory nerves are going to synapse. The olfactory bulbs contain secondary neurons of the olfactory system, send their axons into the olfactory tracts, back here into the olfactory cortex of the brain. Okay, but the point is the sensory endings of these olfactory nerves are located kind of in a roof of the atrium and the nasal cavity. They're high up here. That's called the olfactory epithelium. And the nerves need to get to the olfactory bulb, which is right there on the other side of this bone right here. That's the cribriform plate right there, the ethmoid bone. And so it's got all these tiny little holes in it so those nerves can get through and synapse inside this guy, the olfactory bulb. But anyway, that's the story behind the cribriform plate. Remember, cribriform means sieve-like. Okay, it looks like a sieve because it's got that you might use to drain your spaghetti. All these little holes in it so water can drain. Okay, that's why it's named that. There's not actual water draining through those, it's nerves. Okay, but that's why it's called the cribriform plate. Okay, that's why I said those are the olfactory nerves passing through those olfactory foramina. Okay, now let's talk about those air sinuses a little bit. I told you the head is hollow. The average human head weighs about 10 pounds. Probably would weigh a good 11, 12, 13 pounds if it weren't hollow in strategic locations where it doesn't need to be solid bone. Okay, and here are some of those spaces. We already talked about the middle ear. That's one of them. Okay, of course, the middle ear is more than just a space. It's actually a working part of the, well, say, nervous system. Okay, we need it to hear with. But there are other spaces, really, there's not much going on. They're just simply they're hollow spaces. Okay, so among them are these guys right here. The maxilla is a hollow bone, actually. In fact, there's this massive gymnasium-sized space within the maxilla called the maxillary sinus. And again, don't confuse these with venous sinuses, which are up here in the cranial cavity. Like this one right here is a superior sagittal sinus. That's filled with venous blood. These are different kinds of sinuses. We got two general classes of sinuses. Venous sinuses, by the way, there's the olfactory bulbs right there. I couldn't resist pointing it out. Olfactory bulb, cribriform plate. Here's where the olfactory nerves begin, pass through right there in synapse. Anyway, sorry, that's a tangent. But we have venous sinuses in the cranial cavity filled with venous blood, and then we have air sinuses elsewhere that are just simply hollow cavities. Maxillary sinus right there, right below the orbit right there. There's the eyeball filled with periorbital fat and muscles. And remember I told you about blowout fractures, where this bone right here can fracture and the eyeball and the extraocular muscles and nerves can start to fall through a little trap door right here and fall into the maxillary sinus. That's it right there. Massive space directly lateral to the lateral wall of the nasal cavity right there. So that's a space. And again, you cannot have spaces that don't have communications with the outside world, or you'll get a pinch. You'll feel pain there with any change in ambient pressure out here. So there's a little communication right there. You can see it right there with the nasal cavity. And once you have a communication with the nasal cavity, through the nose, you have a communication with the outside world. Maxillary sinus. And then there are these things called ethmoid air cells right here. Little pockets, little tiny air cells located directly between the orbit, okay, here, and the nasal cavity over here. There they are right there. Those are called the ethmoid air cells. Technically, they're anterior, middle, and posterior ethmoid air cells. I'm not going to ask you to make a distinction between them. I don't think it's that critical. Just know these guys exist. Remember I told you the medial wall, the orbit, is fragile right here. Also relevant to blowout fractures. That's the lamina paprizia right there, that portion of the ethmoid bone that makes up the medial wall. It's almost translucent. You can see, I could look right through this bone right here into that ethmoid air cell right there. Very, very thin, fragile bone right here and right here in the medial wall of the orbit. And then there's a frontal sinus right here, kind of right underneath where the eyebrows are. Eyebrows would be right about here, okay? And there's a sphenoid sinus. The sphenoid bone is also hollow. Don't confuse this with the cavernous sinus, which are, directly lateral to this guy. Those are venous sinuses. They flank the sphenoid bone on either side. We're inside the sphenoid bone right here. Okay, this is the hypophyseal fossa here, the pituitary fossa. Pituitary gland sits right there. Remember, this is our sella turcica. That's dorsum celli, the back of the saddle. Well, the saddle itself is hollow. Or you might say the inside of the horse is hollow. I don't know. But that's the sphenoid sinus right there. That's another one. Okay, so when people say they have sinus infections or sinusitis, inflammation of the sinuses, this is what they're talking about. Frontal sinus is a very common one. Very often you'll have a sinus infection and pain underneath your eyebrows, right above your eye. That's inflammation of the mucosa lining this air sinus right there. Okay, that's what's going on with sinus infections. Okay? Now, one more thing before we talk about the openings of these things. They're all going to open up in a nasal cavity. That's what I'm talking about. Got something else to deal with. It's not an air sinus. This is something completely different. We got to return to the eye right here. Remember, I told you superior and lateral to the eyeball, hanging out right here behind the nasal septum, hanging right out here deep to the orbital septum is the lacrimal gland, which produces and secretes lacrimal fluid or tear fluid onto the surface of the eye to keep it wet. Okay, all that fluid's got to go somewhere. Some of it comes out and drips down our face, but not usually. Now, unless we're very, very sad, and there's a lot of it being produced. Most of that's going to circulate over here immediately and be taken up by this little duct system right here. Okay, there are little tiny holes here and here. You can see them if you look in the mirror. They're called lacrimal puncta. Okay, so there's a lacrimal punctum here. There's another one right there. The two are called puncta. Okay, tiny little holes in your eyelids. Okay, you can see them very clearly. And those are going to lead into these little ducts here called lacrimal canaliculi. Okay, and they are going to converge right here into something called a nasolacrimal sac or lacrimal sac. And that's going to lead down into something called a nasolacrimal duct. That's going to, guess what, head down to the nasal cavity and drain right here below the inferior concha into the inferior meatus. That is how we normally dispose of lacrimal fluid through the nostril right there. Okay, so we got to account for this little opening right there. Okay. Okay, so let's put this all together now. We have a whole bunch of air sinuses as well as the lacrimal system all need to drain somewhere. The air sinuses need access to the outside world, and we have to drain our lacrimal fluid. So, looking again at the lateral wall of the nasal cavity there, in this case, the artist has trimmed away a little bit at the conchi. And so here's the hard palate here. That makes this inferior meatus. This is the inferior concha, which has been trimmed down. So we can see the lateral wall of the inferior meatus a little better. And likewise, this is the middle concha that's also been trimmed by the artist, so we can get a better view of the lateral wall of the middle meatus. And here is just this little thing right here is the superior concha, that's superior meatus. This is sphenoethmoidal recess. Now, let's go through these things. This is sphenoid bone right here, and the sphenoid bone is hollow. Again, this is the sphenoid sinus, airspace basically coated on the inside of mucous membrane right there. Okay, and again, that's going to communicate with the outside world through the nasal cavity and out the anterior nares. And so there's got to be an opening between the sphenoid sinus and the nasal cavity. And we can see actually the opening is right there, indicated by this little metal wire, I guess, that the artist is using right here. Okay, there's the opening right there. And so the sphenoid sinus is going to access the nasal cavity through an opening that leads into the sphenoethmoidal recess. Sphenoethmoidal recess communicates directly with the sphenoid sinus. Okay? Now, there are ethmoid air cells also that are directly lateral to this wall right here, kind of right. Ethmoid air cells would be right behind this wall right here, just lateral to this. And there are actually three different kinds. There are posterior, middle, and anterior ethmoid air cells. Consequently, we're going to have three different openings. Again, I don't really care that you distinguish between the different kinds of air cells, ethmoid air cells. I just want you to understand why there are three different openings, because there are three different kinds of ethmoid air cells. Posterior ethmoid air cells have an opening right here into the superior meatus, kind of right in here like there. So that, again, the hole is not really grossly visible, but it'd be right about here. That's what's happening in the superior meatus, is pretty much this opening to some of the ethmoid air cells. Okay, so there's one opening here in the sphenoethmoidal recess, the sphenoid sinus, opening to some of the ethmoid air cells here in the superior meatus. And then we're going to go down here to the middle meatus, and that's where it gets a little bit complicated. There's lots going on in here. There are basically, essentially, 4 different openings to air sinuses right down in here in the middle meatus. Now, to appreciate these openings, we first got to point out 2 different features here. There's a big bump right here, right underneath the middle concha, and this guy is called the ethmoid bulla. It's a little bump that's hollow, and within this hollow bump right there are some of those ethmoid air cells, specifically the middle ethmoid air cells. I don't care that you know that much. Just know that some of the ethmoid air cells are right in there. Okay, and there's a little hole kind of right in the apex of this thing, right in the apex of the ethmoid bulla, and that's the opening between those ethmoid air cells that are underneath this bump and the nasal cavity. And then over here, you can see right here, there's a little slit right here, a little half-moon-shaped groove here in the lateral wall of the middle meatus, and this is referred to as a semilunar hiatus, okay, because it's half-moon shaped, like a little crescent moon. Okay, and there are actually 3 different openings in this thing. There's an opening here at this anterior end. There's usually an opening at the posterior end, another opening halfway in between somewhere. Okay, and so what do we have here in the semilunar hiatus? We have an opening to the frontal sinus up here. There's our frontal sinus under our eyebrow, and the opening, the frontal sinus, communicates with the outside world via the anterior. That's this little metal wire here. This little metal wire is passing through the opening, kind of communicates with the outside world via the sort of the anterior or superior end of the semilunar hiatus. So frontal sinus communicates with semilunar hiatus, which communicates with the middle meatus, which communicates with the vestibule of the nasal cavity and the anterior nares, and then out to the outside world. Okay. There are also additional ethmoid air cells halfway in between. The anterior ethmoid air cells, which I don't think I've labeled, there would be an opening here to those. And then we go back to the back side of the semilunar hiatus right there. There's usually a fairly large opening right here, and that's our opening to the maxillary sinus. Remember that giant maxillary sinus deep to the maxilla? Okay, it's just directly lateral to the wall down here. And so if I were to remove the wall, the lateral wall of the nasal cavity right here, I would open up that giant maxillary sinus back there. And this is the opening to it there. So it opens up into the superior end of the maxillary sinus. So that's at the back end of the semilunar hiatus. And then lastly, so that's it for the middle meatus. Then we got one opening down here in the inferior meatus, and this is this opening right here. And this is not an opening to an air sinus. Okay, this is something quite different. This is the opening or end of the nasolacrimal duct, and that's where lacrimal fluid is going to be drained into the nasal cavity, okay, right here and into the inferior meatus. And so all together, we put this all together. We've got one opening to an air sinus here. There's the opening of the auditory tube to the middle ear, which is an air sinus with ossicles in it. You know, we don't usually refer to it as an air sinus. It is. Sphenoid sinus is one opening into the sphenoethmoidal recess from the sphenoid sinus, one opening into the superior meatus from some of the ethmoid air cells. There are 4 openings to various air sinuses here into the middle meatus. More specifically, there's a hole in the apex ethmoidal bulla and 3 holes in the semilunar hiatus. I've only shown 2 of them. There's, again, more ethmoid air cells will open up here. And then one opening down here that's not an air sinus at all is the nasolacrimal duct. Okay? And we can see right there, that's where our lacrimal fluid is going. It's going to get spit into the inferior meatus right there, and then out comes our nose. So this explains the rumor that I've heard. I have no direct familiarity with this, that when you cry profusely, your nose will run, because that's where this is where lacrimal fluid is ultimately being drained to, right into the inferior meatus, and then out the nose. I, of course, never cry, and therefore I can only rely on anecdotal stories that your nose will run when you cry profusely. Okay? Now, this is not to be confused with something very different and much more serious. So sometimes your nose will run, and it may not be lacrimal fluid. Okay? It could be, just mucus that's liquefying and coming out if you have a cold or something. That's another thing. But this is something completely different. If you've experienced some kind of head trauma right here, that could result in a fracture to the cribriform plate right there. And so right here, just to get oriented here, right up here is the cribriform plate of the ethmoid bone, okay? And lining that is dura mater and arachnoid matter right there, okay? And this is the anterior cranial fossa right there. That would make this subarachnoid space right there. Frontal lobe of the brain and pia mater would be right about here. So the subarachnoid space right here, okay? And if we were to suffer some kind of injury right here that would fracture this bone and tear the dura mater and arachnoid mater, we now have an open communication through those meninges and the bone right into our nasal cavity. Okay, and so cerebrospinal fluid can actually leak through this cribriform plate right down here and out the nose. Okay, then this is something very different than a runny nose or a profuse crying, because this is cerebrospinal fluid leaking out the nose. Okay, and this is referred to as CSF rhinorrhea. So rhinorrhea literally means a flowing nose. So anytime we have a runny nose, that's rhinorrhea. But this is CSF rhinorrhea, and this is a serious condition right here. And so anytime, here's the moral of the story, if somebody suffers some kind of head trauma and then immediately thereafter their nose starts running, that's a trip to the emergency room, because this is a serious condition. It's quite possible that fluid that's leaking out of their nose, and it should be a clear fluid, okay? It might look like snot or something like that, but it could be cerebrospinal fluid, okay? So I just want you to know the distinction between CSF rhinorrhea and a runny nose and lacrimal fluid, okay? The nose can run for many reasons, and this is the most serious. Now let's move on into the oropharynx next. All right, so here, that's a mouth right there, a tongue depressor right there. There's the tongue. When we look at back here, the back of the throat, back here in this dark area back there, that's the oropharynx, directly posterior to the oral cavity. And we look back there, so the oropharynx is back there, okay? And so here it is back there, this green area right there. Okay, we'll talk about this boundary right here in a little bit, but here's the oral cavity. Here's the oropharynx located below the soft palate and above the epiglottis. We're going all the way back to the back wall of the pharynx right there. This is pharyngeal mucosa lining pharyngeal constrictor muscles right there. And then behind that we have cervical vertebrae. Okay. Now, let's look at some of the things we see back here. As I said, this is mucosa lining the back of the throat, lining those pharyngeal constrictors right there. Okay, and we can see a couple folds right here. There's a fold coming down from the soft palate and blending in with the pharynx right there. That is called the palatal pharyngeal fold. Palatal pharyngeal. These folds are named for where they come from and where they go. Remember, this guy is a salpingo-pharyngeal fold up here, coming from the salpinx, the auditory tube, blending in with the pharynx. Now we have a palatal pharyngeal fold from the soft palate to the pharynx. Okay, and just like with the salpingo-pharyngeal fold, that fold exists for a reason. There is actually muscle deep to that, and the name of the muscle that's deep to the palatal pharyngeal fold is the palatal pharyngeus muscle. There's a tiny little muscle inside there creating that fold. Okay, and then over here we have another fold, only this fold is coming down from the soft palate and going to the tongue. Okay, and so naturally it's called the palatal glossal fold. Palate to tongue. Glossal is tongue. Palatal glossal fold. And again, that fold exists for a reason. There's actually muscle deep to that fold. And the name of that muscle is the palatal glossus muscle right there. Okay. Now, when you look at this, kind of clinically, these two folds here form a pair of arches or pillars. Okay. So this is very often called the anterior arch or the anterior pillar. And this is the posterior arch or posterior pillar that we can trace up to the soft palate, to the uvula practically. It actually follows thing up, and it's actually continuous with the lateral side of the uvula. Okay, so anterior arch, anterior pillar, posterior pillar. Anatomists call it the palatal glossal fold and a palatal pharyngeal fold. Okay. And then in between those two folds, between those two pillars, we find another tonsil. Remember, this is the pharyngeal tonsil or adenoid right here. Well, now we got another little clump of lymphoid tissue here called the palatine tonsil, and it's located directly between those two pillars. When people said they've had their tonsils out, they're talking about their palatine tonsils. Okay, if you've had your pharyngeal tonsil out, people usually say they've had their adenoids out. The tonsils that you get taken out under, if conditions are bad enough, those are the palatine tonsils. And then down here we have lingual tonsils, which to my knowledge are never removed unless the person has tongue cancer. But right down here on the surface of the root of the tongue is the back side of the tongue, the portion of the tongue that's located in the oral pharynx. The rest of the tongue here is in the oral cavity. This is the body of the tongue. This is the apex of the tongue. But the root of the tongue has little bumps on it called lingual tonsils. All right. So there's the root of the tongue with the lingual tonsils right there. And this is with all the mucosa stripped off. Okay. And then we can see the muscle now from palate to pharynx. There's the palatal-pharyngeus fold. Excuse me, the palatal-pharyngeus muscle, which, when you slap mucosa on this, creates the palatal-pharyngeal fold. That's that posterior pillar or arch. And then right here, we see the palatal glossus muscle right there. Again, if I slap mucosa back on this, then I have a palatal-glossal fold or an anterior pillar or anterior arch. Okay, that's it right there. But there's a palatal glossus muscle underneath it. And so this is a muscle that can pull down on the soft palate or pull up on the tongue. Okay. And in between, this would be the bed here of the palatine tonsil. The palatine tonsil has been removed right here. You see a bunch of vasculature here feeding it, but don't worry about that. But the one thing I'm pointing out here is this guy right there. So the other thing we find between these two folds or muscles, in addition to the palatine tonsil, we also, if you dig into even further into the back wall, we find a nice little nerve right here. And guess who that is? That's cranial nerve 9, or the glossopharyngeal nerve. Okay, so he's fresh off from having supplied the mucosa of the pharynx. Okay, originally he was motor to the stylopharyngeus muscle, then he was sensory to the mucosa of the pharynx, and now he's heading for the root of the tongue. And there's a reason for that, because he is sensory to the root of the tongue. Okay, sensory, not motor, sensory. Okay, and so what kind of sensory? Lots of different kinds of sensories. Well, everything. Touch and pain, as well as any taste cells or taste buds that we find on the root of the tongue. Any kind of sensory modality you can think of for the root of the tongue, it's cranial nerve 9. So if I touch the back of the tongue, I'm stimulating 9. If I stick a pin in the back of the tongue, I'm stimulating 9. If I sprinkle some salt or sugar or something else, I'll stimulate taste buds onto the back of the tongue. That's 9. It's all 9 back here. Okay, all the sensory functions to the root of the tongue. It's all cranial nerve 9 or glosso. That's why it's glossopharyngeal. So now you get the whole picture here. Okay, it's sensory to the back of the tongue and also sensory to the pharynx, as well as motor to one pharynx muscle. Okay, now let's look down on the tongue, the back side of the tongue. This is sort of a view if you can get inside someone's oral cavity and look straight back down on the back of the tongue. There's the epiglottis back there. And this just gives us another view of things. So this is the body of the tongue right there. Okay, and this is the root of the tongue right there. All those little bumps there are lingual tonsils. There are the palatine tonsils here and here, flanked anteriorly and posteriorly by a pair of folds. Palatal glossal fold from soft. Remember, the soft palate's hovering over all of this. Palatal glossal fold with its underlying palatal glossus muscle, and the palatal pharyngeal fold from soft palate to pharynx right there with its underlying palatal pharyngeus muscle right there. Okay. Okay, so this gives us a better idea of what we're seeing back here. As we look through the oral cavity, we can see here and here. We can make better sense of what we're looking at right there. So back here, this is the back wall here. We're looking basically at the back wall of the oral pharynx here. This is basically mucosa coating the pharyngeal constrictor muscles. There's a uvula hanging down from the soft palate here. And we can see a pair of pillars coming down on either side of the palatine tonsil. In front here, we have a palatoglossal fold, or we can say the anterior arch or anterior pillar, or as it's labeled here, the palatoglossal arch. I'll accept all those things. And then back here behind the palatine tonsil, we have the palatopharyngeal fold, or as it's labeled here, palatopharyngeal arch, or you can even call it posterior arch, posterior pillar. I like to use palatopharyngeal and palatoglossal because those are the correct anatomical names. But clinicians will say anterior and posterior pillars or arches. Okay, this takes us to the point of the gag reflex right here. So gag reflex basically is what happens, and don't confuse this with cough. That's a different thing. Gag is what happens when something goes down your throat and you react violently to something being in your throat that you don't like. And the most obvious example is if you stick your tongue and try to touch the back of your throat with your tongue, you're going to kind of, well, you're going to gag. Okay, generally speaking, this mucosa back here doesn't like that. So there's the mucosa lining the pharyngeal constrictor muscles. That's the back wall of the oral pharynx. There's a uvula and soft palate there, and we can see anterior and posterior pillars and maybe a little bit of palatine tonsil right there. And so the gag reflex is an important reflex, and again, as always, we test reflexes to test the integrity of the nerves that form that reflex. So we always think about a sensory and a motor limb here, and so to induce a gag, you can either touch the back of the throat, which is mucosa covering the pharynx, or you can touch the root of the tongue. You can even touch the soft palate, although that's the most uncommon way of testing it right there. And so what's the sensory or afferent limb of this reflex? Well, if we touch the back of the throat, that means we're touching the mucosa lining the oral pharynx. Again, that's mucosa covering pharynx. The nerve that's sensory to that is cranial nerve 9. If we touch the root of the tongue, the back of the tongue, and induce a gag, again, that's cranial nerve 9. If you were to induce a gag by touching the uvula or soft palate, just know that's actually cranial nerve V2. That's the maxillary division of the trigeminal nerve. That's not 9. So you can induce a gag this way. Just know that you're inducing it using a different afferent limb, okay, a different sensory nerve. Okay, most time we touch the back of the throat or the root of the tongue to induce a gag. The sensory limb is 9. Now the gag itself is basically a reaction of pharyngeal muscles to the pharynx or root of the tongue being touched. Okay, and so we think about the motor innervation of the pharynx. Well, it's all vagus or cranial nerve 10, with the exception, of course, of the stylopharyngeus muscle, which is the only nerve supplied by cranial nerve 9. Okay, so that muscle is going to be involved a little bit. Mostly it's the pharyngeal constrictors that react. Most of the muscles of the pharynx are supplied by vagus. So gag reflex as a whole is a reflex that tests 9 and 10 as a unit. Okay, unless, of course, you touch the uvula and soft palate, then it's V2 and 10 and maybe a little bit of 9 because it's motor stylopharyngeus as a unit. Most of the time, you want to think gag reflex is being mediated by glossopharyngeal nerve and vagus. Excuse me. Now let's look back a little bit back here. I just want you to know a little bit about this anatomy right here. It's somewhat outside the scope of your practice, but I just want to point out some of the other anatomy here that does have some clinical relevance, although generally speaking, I don't expect you guys will be intubating any patients. It's not really what you do, but you should know about these folds right here that connect the back of the tongue, the root of the tongue, with the epiglottis and the little valleys in between. So here's epiglottis. This is tongue right here, the root of the tongue, and in between we have glossoepiglottic folds. Okay, it literally means from tongue to epiglottis. There's a median glossoepiglottic fold. Okay, it's an unpaired one. There's not a right and left one. There's just one right in the midline, and it's flanked by a pair of lateral glossoepiglottic folds. Notice there are no medial glossoepiglottic folds. That's not a thing. You got one median and a pair of laterals. And in between, there's things called epiglottic valleculi, which are these little pits right here and here. A vallecula is literally a valley. It's a little valley of the epiglottis right here and here. Now, the clinical significance is simply this. This is a Macintosh laryngoscope that can be used to look at the vocal cords or even to start the process of intubating a patient, of getting a nasogastric tube down their throat. But we can look at the larynx this way as well. And the idea is it has two little blades right here. They're called blades, literally. They don't cut. They're just called blades, and you just sit these little blades, like two little legs of the laryngoscope, and you're basically going to sit one here and set the other blade there into these epiglottic valleculi, and that's what positions the laryngoscope so it's looking right down the throat. Okay, and that gives us this view right here. We can get a nice view of the vocal cords. Okay, so that's how these epiglottic valleculae are utilized. They're good landmarks for positioning the laryngoscope. All right, let's go to this view right here. Another lateral view, the nasal pharynx and oral pharynx. Just want to point out something else right here. So there's our palatal glossal fold right there, connecting the soft palate with the tongue right there. This is not labeled, but this is the palatal pharyngeal fold right there. Palatine tonsil would be right in here. Okay. And we can see there's an opening right here that coincides with the palatal glossal fold right here. Okay, there's an opening right here, but again, the oral cavity is a space, oral pharynx is a space, and as always, anatomists cannot help themselves but to name the openings between spaces and give them names. And the name of this opening right here, separating the oral cavity from the oral pharynx, is called the fauces. Just like we had a quana up here, separating nasal cavity from nasal pharynx, separating oral cavity from oral pharynx is the fauces. Okay, that's what it's called, because that's what it is. Okay, let's look in the oral cavity. And again, this is it. Once we get through the oral cavity, we're finished with anatomy. All right, so this is showing you where the fauces is again, looking down on the tongue. Here's our palatal glossal fold here and here. And the fauces is basically an opening. And it's hard to draw. This is a two-dimensional drawing here. What I'm trying to indicate here is an oval-shaped opening here in a coronal plane, directly between these two arches right here, and that's the fauces. So if I'm on this side of the fauces, I'm in the oral cavity. If I go to this side of the fauces, I'm now in the oral pharynx. Okay, that's the fauces right there. Okay, and let's look at the tongue a little bit and talk about its sensory innervation. Okay, the root of the tongue, okay, which is that portion of the tongue that resides in the oral pharynx behind the fauces. Again, formally, that's called the root of the tongue, and it's, you can see it's got lingual tonsils all over it. And we already talked about its sensory supply. The sensory innervation of the tongue, the root of the tongue, is going to be cranial nerve 9. And it doesn't matter, general sensory and taste buds, it's all 9. Now, the body of the tongue, which is this portion here, as well as the apex here, remember, has that split innervation. Ultimately, by the time we get to the oral cavity, it's all lingual nerve. But remember, lingual nerve is carrying axons from another nerve. General sensory supply, the anterior two-thirds of the tongue and the apex, so touch and pain, is going to be the lingual nerve proper. Axons that travel with the lingual nerve and stay with the lingual nerve, which is a branch of V3. Okay, that's general sensory. But then special sensory, meaning taste cells and taste buds, okay, those are also running with lingual nerve, but remember, when we get to the infratemporal fossa, those guys will get off the off-ramp and travel with chorda tympani, which is a branch of cranial nerve 7, or the facial nerve. Again, they'll run together. All these sensory fibers, pain, touch, and taste buds, all run together for a little while along the lingual nerve, but they will separate eventually. So this slide is primarily just review right here of the sensory innervation of the tongue. As I forgot to point out here, the boundary here, there's a little chevron-shaped line right here that is the formal separation here between the body of the tongue and the root of the tongue. This is called the terminal sulcus right there. Remember, sulcus is a groove, and that's called the terminal sulcus. That's the formal boundary right there between the body and root of the tongue. All right, now we got to get into the oral cavity and start get a better view of the muscles that make up the tongue, as well as nerve supply and arteries and all that stuff. So we're going to finish our job of bisecting the head, and we're going to bisect the mandible. But first, as always, before we start cutting bones, we got to first cut the soft tissues. And so what we do, we start in a submental triangle using a scalpel. We're going to cut right here down the midline, right there, separating the two mylohyoid muscles. There's our right mylohyoid, there's a left mylohyoid. Remember, they insert into each other along a midline raphe. Well, basically, we're going to obliterate that raphe and separate the right and left mylohyoid muscles from each other, taking a lot of, what's the word I'm looking for? Being careful to avoid the anterior bellies of the digastric muscles. We don't want to ruin those. Okay, so we're going to make this cut right there. Okay, and then now in the oral cavity, and this is done again from the submental triangle, but we got to remember on the other side of the mylohyoid, there's our right mylohyoid, there's our left mylohyoid. Inside the oral cavity, we've got these horizontal muscles right there, going from chin to hyoid bone, called the geniohyoid. And these are the final suprahyoid muscles that we can only see from the inside of the oral cavity. There they are right there. It should not be confused with the anterior belly of the digastric muscles. These are on the other side of the mylohyoid muscles. And a lot of care has to be taken to make sure we stay between these two muscles and separate them from each other rather than mutilate them. Okay, but these are the geniohyoid muscles right there. Okay, and so the idea is to try to gently separate them from each other. Okay, keep them intact. And then finally, once all those soft tissues are eliminated, then we generally go in with a bone saw and saw through the mandible, but not the tongue. The tongue should be bisected with a scalpel. And this is how we do it. We're going to bisect the tongue right here from apex down the body through the root, but not the epiglottis. The epiglottis is never bisected. There's never any good reason to do that. And not the hyoid bone either. The hyoid bone is not separated, but the tongue is bisected. So the right and left halves will be on different sides of the head. Okay, so all that is just to get oriented here. Now let's look at some of the muscles around the tongue. Now this is a lateral view of the tongue right here. Okay, and we can see the tongue is actually made of muscle right here, but there are a whole bunch of other muscles that interact with it. There's a hyoid bone back there. There's the cut surface of the mandible right there, the body of the mandible. And just know that the word genio, or the prefix genio, means chin. Mental means chin in Latin. Genio means chin in Greek. And so this is the genio right here. Okay. There's a mylohyoid muscle right there. And you can see it's a very, very thin muscle right there. That's all it is. It's a sheet of muscle forming the floor of the oral cavity right there. And then right there, just superior to it, are those two kind of anteroposteriorly oriented horizontal cylinders of muscle right there called the geniohyoid muscles. Okay, from chin to hyoid bone. And these are the last of the suprahyoid muscles. So digastric, anterior and posterior bellies, stylohyoid, mylohyoid, and now finally the geniohyoid are our four suprahyoid muscles. So there's our geniohyoid right there from chin to hyoid bone. And then let's look at the tongue itself. Now the important thing is geniohyoid is not a tongue muscle. Okay, it's a suprahyoid muscle. Its job is to move the hyoid bone around. Okay, it's not going to the tongue. Now we're going to deal with actual tongue muscles. Now the first thing to understand, the tongue is muscle. It is made of muscle. The parenchyma of the tongue, the mass of the tongue, is basically just solid muscle with mucosa on top of it. Okay, and we call it the intrinsic muscles of the tongue, the muscles that actually make the tongue. But then there are a whole bunch of muscles that insert in the tongue and act to move it around, and so we're going to run through those. The most prominent, honestly, and probably the most important, is this guy right here, this giant fan-shaped muscle. So it's fanning up, fanning up, fanning up, fanning up, inserting into the tongue everywhere. Even these fibers here are going back to the root of the tongue back here. Okay, this giant fan-shaped muscle that starts on has its origin on the chin and inserts into the tongue is the genioglossus muscle. So literally from the chin to the tongue. Okay, so we have a geniohyoid from chin to hyoid bone, not a tongue muscle, and a genioglossus muscle. It is a tongue muscle. It ends in glossus. It's a tongue muscle. That's what that means. And so this right here is it, and that's the prime protruder of the tongue. When I stick my tongue out, I'm using my genioglossus to do that. Its job is to yank on the tongue and shove it out of the face this way. Okay, that's what the genioglossus does. Then we got other muscles, and we talked about this one. This is the palatal-glossus muscle. This is that muscle that underlies the palatal-glossal fold, the anterior pillar. That's it right there. And that's a tongue elevator. Okay, it's taking its origin up here, and it starts into the tongue, so it's able to elevate the back side of the tongue. It also can depress the soft palate. It can work in both ways. Okay, that's the palatal-glossus muscle. Okay. This is a muscle we know as well. We talked about this guy down when we talked about the submandibular triangle down there. We talked about this is our stylohyoid muscle here. There's the digastric muscle, or at least what's left of it. The anterior belly has been removed. The posterior belly is this thing right here has been removed. There's the intermediate tendon of it. Remember, the stylohyoid muscle straddles it. Well, over here, so that deep to that right there, remember we had that hyoglossus muscle. Okay, there's a hyoglossus. Remember, the mylohyoid would be kind of covering it right there, and the hypoglossal nerve passes in between the mylohyoid and hyoglossus. Well, there it is. Again, it's a muscle. It's not a hyoid muscle, okay, because it doesn't end in hyoid. It starts with hyo because it's taking its origin off the hyoid bone, but its insertion is the tongue. So this is a tongue muscle, not a hyoid muscle. Its job isn't to move the hyoid bone around, it's to move the tongue around. Hyoglossus, from hyoid to tongue, okay? And its job is it's a retractor and a depressor of the tongue. So it can pull down and back on the tongue, mostly a depressor, a little bit of a retractor. And then the prime retractor of the tongue is going to be this guy right there. This is the styloglossus muscle, not stylohyoid. That's this muscle right here going to the hyoid bone. This is styloglossus. And it's going to insert, it comes off the styloid process of the temporal bone. It's going to insert in the tongue all along here. And so it's capable of pulling the tongue back in. If I stick my tongue out, I better have a muscle that can pull it back in, or I'm going to be walking around like that for the rest of my life. I suppose I always push it back in with my finger, but that's not really very efficient, and probably not a good thing in the world of COVID-19. Okay, so that's styloglossus, and so that's a retractor and elevator of the tongue. And so those are the big four, right? Yeah, it's four. Four extrinsic muscles of the tongue, the four muscles that insert into the tongue to move it around. Okay, now, so let's look at some of the surface anatomy in and around the tongue. We're looking down on these are inferior teeth or mandibular teeth down there. And we're looking at the floor of the oral cavity. Let's see if they've had their wisdom teeth taken out. Oh, they have. So you guys should probably know how many teeth there are. So adults have 32 teeth unless they've had their wisdom teeth taken out. So 1, 2, 3, 4, 5, 6, 7. Times 4 is 28, so this person has no wisdom teeth. Anyway, who cares? We're not trained to be dentists here. But looking down here is where we're really interested in right here. This is the tongue that's been lifted right here. So we're looking at the bottom of the tongue, and this little thin piece of mucosa here connecting the tongue to the floor of the oral cavity. This is referred to as the frenulum of the tongue. Okay. Clinical side note: ankyloglossia, which is being tongue-tied, clinically speaking. Okay, ankyloglossia literally means tongue-tied. Okay, is a congenital condition. Babies are born sometimes with frenula that are really, really short and thickened, and they can't move their tongue around efficiently. And it's technically a surgical procedure, but it's done, pretty quickly within the what's the word I'm looking for, in the maternity ward. We just go in and trim down this frenulum a little bit. There's a little instrument that's been designed just for that purpose. And you can trim this down and make the tongue more mobile. But that's ankyloglossia, the condition where the frenulum is too thickened or short and the tongue can't move around well. Okay? Now over here, this ridge right here, and by the way, you can look at all this stuff inside your own mouth. Okay, all you gotta do is look in a mirror and you can check out all this anatomy right here in your own face. And this little ridge right here underneath your tongue on either side is called the sublingual fold right there. And as always, when there's a bump, there's usually somebody living underneath it. And indeed, what's living underneath it is a gland called the sublingual gland, which is the final saliva gland. So we have a parotid gland. We've talked about that. We've talked about the submandibular gland. That's done. Here's the last one. The sublingual gland is right there under the tongue. Sublingual. Lingual is the other word. Glossus means tongue. Lingual means tongue. So this is the gland under the tongue. And then this thing right here is a little bump right here and here called the sublingual caruncle. It's got a little opening right there, and that's actually the termination of the submandibular duct from the submandibular gland. Not the sublingual gland, but the submandibular gland. Okay, although the sublingual gland will sometimes drain to this little opening right here as well. Okay, that's the sublingual caruncle. And again, these are things you can see inside your own mouth. Okay, so there they are. Again, this is more cartoonishly, so the tongue has been elevated. There's a sublingual fold, and has a whole bunch of little openings all along the ridge. These are the many, many ducts, usually about 15 on either side. The many, many ducts from the sublingual gland, and this is the sublingual caruncle on either side of the frenulum of the tongue. And that's the opening of the submandibular duct. Okay? Looking at the anatomy with all the mucosa stripped off, we can start to see what's going on here. Okay, there's our sublingual gland. So this is the submandibular gland right there. Most of it resides in the submandibular triangle of the neck, and it's going to hook around inside the oral cavity right there. But that's different than the sublingual gland right there, which is right underneath the sublingual fold right there. And you can see there are ducts all on the top of this thing right there. That's the sublingual gland. Okay, there's a submandibular gland. Again, it's kind of a C-shaped gland. Part of it's located superficially or inferiorly below the mylohyoid muscle, which is this muscle right there. And part of it turns around, kind of hooks around the free edge of the mylohyoid right there, hooks around a free edge and goes inside the oral cavity. And that's the deep part of the submandibular gland. And then right there is a submandibular duct. So that's a duct from the submandibular gland. And relationships are key to identification. We can see that duct is not green in real life. That's just the artist's rendition of it. It runs along the medial side of the sublingual gland. The duct is not coming from this gland. It's coming from this gland, but it runs right alongside the sublingual gland right there and terminates right there at the sublingual caruncle, which would be right there. So that's an important relationship. Submandibular duct is running along the medial side of the sublingual gland. And note the other thing, it doesn't go to the tongue. Saliva does not squirt out of our tongue ever. So it's not going to the tongue, as opposed to some nerves which are. Okay, let's look at the nerves. This is review. Parasympathetic innervation to the oral cavity, including these two glands here and here. Okay, starts off cranial nerve 7. Okay, it contains preganglionic parasympathetic axons traveling with chorda tympani. Okay, the chorda tympani is going to join with the lingual nerve right there. Okay, and travel into the oral cavity. Okay, preganglionic parasympathetic axons that have been traveling with the chorda tympani and then with the lingual nerve right about here in the oral cavity will get off and go into this ganglion right here. And this is our last parasympathetic ganglion. We talked about the otic ganglion, which hangs around here. We talked about the ciliary ganglion in the orbit. There is one more parasympathetic ganglion that I didn't talk about, nor will I. And then we've got this guy right here, the submandibular ganglion. So these guys will go in, synapse in this ganglion on postganglionic parasympathetic neurons. And then those neurons will send their axons into the submandibular gland, and some of the fibers will go back to the lingual nerve and head over and go into the sublingual gland. So this ganglion here is postganglionic parasympathetic to both the submandibular gland as well as the sublingual gland. Okay, continuing on with the oral cavity, a couple other things to look at here. So there's the hyoid bone here, just get oriented. Here's our submandibular duct right there that's going to terminate on the sublingual caruncle. Okay, we got two nerves going into the tongue that we need to deal with. There's a lingual nerve right there, and note the distinction here. Okay, lingual nerve. Okay, the submandibular duct actually goes up and over the lingual nerve, but it doesn't. Submandibular duct does not go to the tongue. It goes to the sublingual caruncle. The lingual nerve, which ducts under the duct, will go into the tongue. And the reason it's going into the tongue is because it's going to be sensory to all of this right here. Okay, touch and pain, as well as the fact that it's bringing in sensory fibers from chorda tympani. They're going to supply taste buds here as well. Okay, so it's actually going into the tongue. Okay, there's a submandibular ganglion I talked about. That's going to be postganglionic parasympathetic to the sublingual and submandibular glands. And then down here is the hyoglossus muscle right there that's been cut here and here. There's the hyoglossus. Okay, and then right here running superficial to the hyoglossus is the hypoglossal nerve. That's it right there, cranial nerve 12. And notice it's much lower than the lingual nerve. So two nerves are going to go into the tongue, but the lingual nerve is significantly superior to the hypoglossal nerve. That's why it's called hypoglossal. Hypo means underneath or inferior to. This guy is inferior to the tongue. So it's cranial nerve 12, and this guy is going to be motor to most of the tongue muscles. Okay, this guy, lingual nerve, is sensory. Okay, and there's a lingual artery. Remember, this is a branch coming off the external carotid artery that's going to pass and go deep to the hyoglossus, and that is the oxygenated blood supply to the tongue. That's the lingual artery. And remember, the hypoglossal nerve and the lingual artery are separated from each other by a hyoglossus muscle. Okay? So, looking at the oral cavity again. So, there's our lingual nerve right there, which is a branch of cranial nerve V3. Okay, coming down from the infratemporal fossa. There's V3 coming down through the foramen ovale. Keeps going this way. This is lingual nerve. Okay, and there's hypoglossal nerve there. Remember, it's going to pass down briefly into the carotid fossa of the neck, and then pass deep to the posterior belly of the digastric and intermediate tendon and the stylohyoid muscle there, and show up here in the submandibular triangle right in here, deep to the submandibular gland, and then pass deep to the mylohyoid muscle, go into the oral cavity, and onto the tongue, to which it's motor. Okay, hypoglossal nerve is motor to the entire tongue, except for most notably the genioglossus, okay, which protrudes the tongue, except for one muscle, the palatoglossus muscle. That's the only exception. Okay, again, clinically, the most significant muscle is the genioglossus because that's the muscle that sticks the tongue out. All right, so let's look a little bit at the dynamics of how the genioglossus muscle works. Now, what we're looking at, so there's our genioglossus right there. Remember, it's from chin to tongue by definition, and it's a protruder of the tongue, meaning it's going to move the tongue out this way, out of the mouth. Okay, so you ask the patient to stick their tongue out, you're asking them to contract their two genioglossus muscles. So there's a right one and a left one. Both take their origins close to the midline off the chin, and they're going to fan out into the tongue. And so what we're looking at here, and this is a really, really old image because there's like one anatomy textbook I could find that showed an inferior view of the tongue and the insertions into the tongue by these two muscles right there. So this is an old image from like a 19th century anatomy textbook, but these are the two genioglossus muscles on the right side and the left side right there. And the way these things work, so you want to imagine what would happen if we had a hypoglossal nerve injury and consequently weakness of one of the genioglossus muscles. Okay, and to understand what the tongue is going to do when the patient is asked to stick their tongue out has everything to do, as always, with the origin and insertion and vector of pull of these muscles. So let's say in our case, it's the right genioglossus that's weakened. Let's say we have a right cranial nerve 12 lesion, and this muscle, we either have paresis or paralysis of the right genioglossus muscle. Now, what you gotta imagine is that not only is this muscle pull the tongue out, but it's also pulling the tongue towards the midline because the origin is right at the midline, right at the chin. And so the right genioglossus is trying to pull the tongue towards the midline, and so is the left. And so what's going to happen is if you have weakness of the right genioglossus and the left genioglossus is relatively unopposed, when the tongue is stuck out, it's going to go like this. Okay, it's going to deviate by the left genioglossus pulling towards the midline. Okay, as it protrudes the tongue is going to overshoot and go from left to right. Okay, so the tongue is going to be sticking out and deviating towards the right side. And so that's why we say with cranial nerve 12 lesions, the tongue generally points toward the side of the lesion. The tongue is pointing towards the right. That means the problem is on the right. Okay, this guy is overshooting the midline, causing the tongue to deviate. Okay, so to test this idea, which nerve is injured in this case? So the patient is asked to stick her tongue out, and the tongue is going to deviate. In this case, which direction is that? Okay, first thing we got to do is figure out what direction the tongue is going. Remember, nobody cares about your right and left. All that matters is the patient's right and left. Which way is it going? I would say that's towards the patient's left. We're facing the patient, so our right is the patient's left. So the tongue is deviating towards the left. And so which nerve has been injured? Okay, this is a left-sided cranial nerve 12 lesion. The tongue points toward the lesion. So the issue is the right genioglossus, which is pulling the tongue towards the midline this way, is overpowered, or it's unopposed. The left genioglossus, which is trying to pull the tongue this way, is weakened, and so the apex of the tongue as it leaves the face is deviating across the midline to the contralateral side, the contralateral to the strong muscle, okay, and it's deviating towards the side of the weakened muscle. Okay, let's talk about asymmetric elevation of the palate as well. Okay, now in this diagram, this is similar to the other diagram I showed you, but in this case, we're not showing the tensor veli palatini, we're showing the levator veli palatini on both sides. Again, this is a posterior view right here. This is standing behind the patient, looking in their direction. Looking the same direction they're looking, okay, which means our right is their right and our left is their left. And so this is the right levator veli palatini, this is the left levator veli palatini, which you want to imagine how these muscles work and what would happen if we had a cranial nerve 10 lesion. So this guy is supplied, the right levator veli palatini is supplied by the right vagus, left veli palatini is supplied by the left vagus. And both of these muscles are going to pull straight up on the soft palate. And we'll say we have a cranial nerve 10 lesion, okay? All right, so let's say it's the right cranial nerve 10 that's lesioned right there. So that means there's going to be paresis in this muscle. This muscle is going to be weakened because the right cranial nerve 10 has been compromised, which means this muscle is going to be stronger than this muscle. Okay, so this muscle, the left levator veli palatini, is left unopposed or only partially opposed by the right one. And so which side of the soft palate is going to be raised higher? Okay, and the answer is this side. Okay, the left levator veli palatini is unopposed, and so this side, the left side of the soft palate, is going to be elevated higher than the right side. And so we're going to have asymmetric elevation, this side higher than this side. And very often, as this side is lifted higher, it'll drag the uvula in that direction, okay, in the process. Okay, so the uvula, you can't always count on the uvula pointing to tell you which side the lesion is on, but if the uvula does point in one direction or the other, it's going to point away from the lesion. So this side of the soft palate will be raised higher, and the uvula, if it does deviate from the midline, will be pointing away from the side of the lesion. Okay, so in this patient, okay, the patient is being open their mouth to say, the soft palate is being elevated. And we can see that there's asymmetric elevation of the soft palate and the uvula is deviating towards one side. And so the question is, which cranial nerve is being affected and which side? Okay, so the first thing we have to establish is which side of the patient is their right side and which side of the patient is their left side. Again, we're facing the patient, so our left is their right and our right is their left. And so I would say the soft palate is being elevated higher on the patient's right than on the left. So it's being elevated higher on the right than the left, and the uvula seems to be pointing towards the right side. Again, the right side of the patient. Nobody cares about your right side. Okay? And so this would be a left-sided cranial nerve 10 lesion. Okay? This is the side. This side is being elevated nicely. There's weakness in elevation on this side, the patient's left. And a uvula, if it's pointing anywhere, okay, other than the midline, it's going to be pointing away from the side of the lesion. Uvula is pointing towards the right. That means the problem's on the left. Okay, that's it. Kind of a long lecture. I apologize for that. But what I've finished with is basically just a table for your use. I'm going to go through this, but I'm basically going to read it to you. You can read on your own, so you can skip the rest of the audio for this lecture if you want and just read this quietly to yourself. But I'm going to walk you through it anyway, because why not? But basically what I've just ended with, I think, 4 tables here that basically summarizes all of the innervation to the head, basically. You're welcome. I didn't have to do this. I just felt like doing it because I thought it'd be fun. Okay, but this basically summarizes everything, and each slide has a different modality to it. So this slide right here to start with, we'll talk about branchial and somatic motor nerve supply to the head. So branchial and somatic, I'm combining them both in the same slide. Okay, so we're talking about muscles and their motor supply. So basically, muscles of facial expression, okay, cranial nerve 7, without exception. Okay, muscles of mastication, cranial nerve V3, the mandibular division of the trigeminal nerve, no exceptions. Eye movements, okay, it's going to be 4 for the superior oblique, 6 for the lateral rectus. All others is going to be cranial nerve 3. Levator palpebrae superioris, the prime lifter of the upper eyelid, that's going to be cranial nerve 3 as well. Okay, pharynx muscles. Okay, this is relevant to the gag reflex. This is the efferent or motor limb of the gag reflex. We're talking about motor supply of the pharynx. It's all cranial nerve 10 with one exception. Stylopharyngeus muscle, the one single solitary striated muscle that's supplied by cranial nerve 9. Okay, larynx, well, it's all 10. All 10, but you do need to know the branches. External laryngeal nerve, the cricothyroid muscle, that one single muscle of the larynx that's on the outside, that's the tensor of the vocal cords. All the other muscles are supplied by the recurrent laryngeal nerve / inferior laryngeal nerve. Okay, so you need to know the branches. These 2 branches are going to be motor, but it's all 10 ultimately. This is relevant to the cough reflex. Again, anything gets into the larynx and touches its mucosa, it's going to induce a cough. Okay, and this would be part of the efferent limb of the cough reflex. Also, don't forget about neurogenic hoarseness. If we damage the recurrent laryngeal nerve on one side only, the patient will generally have a hoarse voice as a result. Palate muscles, we just covered this. Okay, so this is relevant to soft palate elevation, but clinically, mostly you're testing the levator valli palatini, but the 2 muscles that elevate the soft palate are levator, I'm getting tired, levator valli palatini and tensor valli palatini. There's also musculus uvuli as well. That's the 3rd muscle. Okay, basically it's all 10 except for tensor valli palatini, which is cranial nerve V3 again, the mandibular division of the trigeminal nerve. Tongue muscles, that means anything ends in glossus. Okay, it's all cranial nerve 12. Again, as always, there's got to be an exception, and there is one, and the exception is the palatal glossus muscle. That's actually supplied by vagus, or cranial nerve 10. And you kind of think of this, if you think of this as a palate muscle, and it does kind of depress the palate a little bit, if you think about this as a palate muscle, you can actually move him to here and call him another palate muscle, and he falls into the general rule that's all cranial nerve 10 except for this guy. So in a way, there's kind of an interaction here. Palatal glossus can be put in this category or this category. You put him over here, is not really an exception to the general rule that 10 does a soft palate. You put him here, well, it is an exception. Anyway. All right, autonomic supply. Okay, so that's the other side of the motor nervous. So now we got visceral motor. Okay, so this basically summarizes most of what you need to know. I am leaving some things out. I never did tell you how the lacrimal gland guides innervation or all the mucosal glands. I'm not asking you to know it. It's a complicated pathway involving a 4th parasympathetic ganglion. You can look it up on your own if you're really interested. These are the ones I ask you to know. Dilator pupillae, well, that's sympathetic. So we're thinking preganglionic, that's T1 spinal cord, the nucleus of Budge, we call it, up the cervical extension of the sympathetic trunk to synapse in the superior cervical ganglion. And then using all sorts of complicated pathways, much of which involves the internal carotid artery, okay, sympathetic axons find their way all over the face and travel into the orbit and ultimately to the dilator pupillae from the superior cervical ganglion. That's where the postganglionic neuronal cell bodies are located, and the pathways are really too complicated to know. Don't worry about it. Just know this guy supplies this. Smooth muscle and facial cutaneous vasculature, sweat glands, erector pili muscles. So that's another sympathetic supply right there. And again, it's the same pathway. Preganglionic is this, postganglionic is coming from this guy. And remember, loss of all of this right here and this. Okay, we knock all this out through some lesion and we get Horner's syndrome. Okay, the sphincter pupillae, or sometimes called the constrictor pupillae muscle, and the ciliary muscle, the muscle that controls accommodation. This is parasympathetic. Preganglionic is going to be via cranial nerve 3. For those taking neuroscience, remember it's coming from Enge or Westphal. Cranial nerve 3 to synapse in the ciliary ganglion, where the postganglionic parasympathetic cell bodies are located. Their axons are going to travel by short ciliary nerves into the back of the eyeball to ultimately supply this and this muscle. Okay, and then we got spit glands. Submandibular and sublingual have a similar pathway or same pathway, and then this guy has his own pathway. Submandibular and sublingual glands, we start with cranial nerve 7. That's preganglionic parasympathetic. Okay, a branch of it is chorda tympani, which actually passes through the middle ear on the way into the infratemporal fossa where it joins the lingual nerve, ultimately to synapse in the submandibular ganglion. And then this guy is in a close location in the oral cavity where we can supply these two glands by some unnamed nerves. Okay? Parotid gland, we start with cranial nerve 9 this time. That's preganglionic parasympathetic. Ultimately travels via, there's a branch called the tympanic nerve or Jacobson's nerve that's also going to pass through the middle ear, pops out as a lesser petrosal nerve in the middle cranial fossa, passes through the foramen ovale to synapse in the aortic ganglion, which is in the infratemporal fossa, right behind cranial nerve V3. Axons from these neurons are going to jump on the auriculotemporal nerve, which takes them right out to the parotid gland, where it then gets innervated. Okay, so that's a quick summary of all the visceral supplies. General somatic sensory nerve supply to the head works like this. Facial skin, well, it's trigeminal. V1, V2, V3. Know your dermatomes. Okay, soft palate. Okay, its sensory supply is V2, the maxillary division of the trigeminal nerve. Okay, tongue. Okay, again, we got trigeminal again. Kind of think of this as more face here. Okay, at least the front of the tongue is part of the face. Cranial nerve V3, the mandibular division of the trigeminal nerve, specifically the lingual nerve, which goes the apex and body of the tongue. Remember, the root of the tongue is cranial nerve 9. As is the pharyngeal mucosa, that's also 9, and that's relevant to the gag reflex. That's the afferent limb of the gag reflex. And remember, the nerve supply of the larynx, all of it, whether it be sensory or motor, it's always 10. Cranial nerve 10 is the exclusive cranial nerve with rights to supply the larynx. Only now we're talking about sensory supply to the larynx, so cough reflex, okay? So what are we dealing with? 2 branches of 10. Internal laryngeal nerve, that's that guy that pierces the thyrohyoid membrane to go inside the larynx, and that's going to supply the mucosa above the vocal folds. The mucosa below the vocal folds is going to be done, again, by the recurrent laryngeal nerve, that same guy who is motor to most muscles. Okay, but it's all 10 in the end. Okay, and then finally, the special sensory nerve supply. So the special senses, and olfactory epithelium in the nasal cavity, that's cranial nerve 1. The olfactory nerves, remember, pass through the cribriform plate of the ethmoid bone to synapse in the olfactory bulb. Okay, the retina that we use to see with, that's cranial nerve 2, the optic nerve. Taste buds on the tongue, well, it depends where on the tongue. If we're talking about apex and body of the tongue, we're talking about cranial nerve 7, specifically chorda tympani, and ultimately joining the lingual nerve. Talking about the root of the tongue, it's 9, and then auditory and vestibular, of course, is cranial nerve 8, which is the vestibulocochlear nerve. Okay, that's it. That wraps up all of the head and neck stuff. It wraps up anatomy. The only thing left is, again, I'll be posting review lectures for the practice lecture quizzes, but that's it for all new material. That wraps up anatomy. So, okay, let me know if you have any questions, as always.